Welcome to everyone. I'm Will Montgomery, the presiding officer of the Oversight Committee of the Cancer Prevention and Research Institute of Texas. I'm calling this meeting of the Oversight Committee to order at 10:05 a.m. We have a quorum today, but we will lose the quorum at 1. One of our members must leave at 1 o'clock. So everyone who is planning on speaking, if you could keep your remarks as short as possible. We don't want to shortchange any of the important business. However, we do have quite a number of things to do, particularly some really terrific grants to make. Will the board secretary take attendance of the Oversight Committee, Mr. Patel?
Certainly, I would like to take advantage of this. I'll leave that a little tape. I'll roll call Mr. Andrew here, Mr. Margot here, Mr. Montgomery
here,
Dr. Rice here.
Dr. Rosenfeld is unavoidably unable to attend. I'd like to have a motion to give him an excused absence.
So, second.
All in favor?
Aye.
Aye. Members, the draft minutes from the May 16th Oversight Committee are available in your agenda packet behind tab 1. Are there corrections or emendations to those minutes? Hearing none, I'll entertain a motion to approve those minutes.
So moved.
All in favor?
Aye.
We're doing great. Our next agenda item is public comment. Public feedback is critically important because CPRIT was created to help Texans. Opening our meetings with public comment underscores this board's commitment to transparency and accountability. Are there any requests for public comment? Hearing none, we will continue. We have invited Dr. Barbara Turner, a CPRIT Prevention Program grantee, to provide a presentation to the Oversight Committee today on the work she is doing. Dr. Garcia, I'd ask you to introduce Dr. Turner. Thank you.
Yes, I'm happy to introduce Dr. Turner. She is currently Professor of Medicine at UT Health San Antonio and the founding director of the Center for Research to Advance Community Health. She's a practicing internist and a health services researcher. Her research is really focused on improving the quality of care, of primary care for vulnerable populations. And since 2013, she's focused her research on implementing screening for hepatitis B and C. And because of that, she's been recognized by the U.S. Department of Health and Human Services for that work. She has 2 CPRIT grants and 2 federal grants. And so it's my pleasure to introduce Dr. Barbara Turner to you.
Thank you. Well, it's a real honor, and I'll be 15 minutes, I promise, to give you a little bit of an oversight of the work we've been doing in San Antonio. And it is really a health disparity story. You probably are well aware of the fact that both the professional press and the lay press has been really focusing in on liver cancer because it is growing in the United States. And I think what the ACS says is quite prescient, which is it is a story of healthcare disparities, racial ethnic disparities, and that we have to prevent liver cancer through effective means that we currently have, but we're not employing. So Texas is an epicenter. As you can see in the red here, South Texas is an epicenter of liver cancer. And if you drill down to counties, you actually get a better specific look at the areas which are hotspots for liver cancer. And it is true that Texas itself is really one of the highest infected, has more liver cancer cases than any other state in the country, but it also has the highest rate. So it is disproportionately affected. So HCV, why am I doing HCV? Because hepatocellular carcinoma is the most common primary form of liver cancer, and it is the dominant cause of it. And we have millions of people in the United States who have HCV. Half of them don't know it. So what we've been trying to do is identify people before they get to cirrhosis. Once they get to cirrhosis, they have a measurable risk every year of getting HCC. And then, of course, HCV causes liver transplants and other costs to society. society and to the individuals. So back in 2013, the United States Preventive Services Task Force put into place a recommendation that we test every baby boomer. I hope everybody here has been at least once who's baby boomer. But at the time, there was really no model for implementing this, and especially there are significant challenges for low-income populations. The USPSTF says everybody needs to pay for it. Well, only if you're insured. So if you're uninsured, there's no coverage. You have poor access to specialty care even if you are insured. And these drugs are expensive even though they're awesome and very effective. So we've had 4 major programs, started back in 2012 actually with CDC funding, where we started implementing in hospital, and I'll tell you about that. And then 2 programs through Medicaid waivers, one in the Valley, one in San Antonio, and then we've been very fortunate to have a program which has 2 major foci through CPRIT, both in South Texas and up in Dallas and Parkland. So 10 healthcare systems altogether, 39 clinics, and we've screened over 50,000 Texans and identified almost 3,000 who are antibody positive. It's about a 6%, almost 6% antibody positive rate, which is about double that in the United States, elsewhere. And of those, most have gotten RNA testing to see if they're still infected. And we've identified 3.5% who have chronic infection and don't know it. So that's about 1,800 people. Now,
do you break those down by racial group as well?
Yeah. And I have to say that in Dallas, it is predominantly African American more than any other group, and of course down in South Texas, it's dominantly Hispanic. Yes.
I'm sorry to interrupt. So the 3.5% with chronic infection, are those the ones that's at a particular risk for hepatocellular carcinoma, or
Not
are
all.
they all?
Not all. No. I would say about, well, it depends, and I'll show you some slides. But if you had advanced liver disease measured by certain metrics, and I'll show you, then you are. And so Hispanics are at significantly increased risk compared to everybody else of having advanced liver disease at diagnosis. And I'll show you. Yep. So anyhow, 7 primary care systems that use specialist teleconsultation. People probably know about an echo model. This is really slimmed down to make it happen for these practices, and that helps them take care of the patients themselves. So CPRIT-funded programs, we've tested about 25,000 people, and you can see the rates in Dallas are somewhat lower than South Texas in terms of antibody positive, but higher in terms of RNA positive. Part of it is in South Texas getting the RNA test is more of a challenge, but nevertheless, we have appreciable percentages with chronic infection, very low rates of HCC that we've identified through our screening, but somewhat higher in Dallas. And we don't want to find that. We want to find people beforehand. But just to mention this thing about advanced liver disease, because that's what we do focus on. And we do it based on laboratory testing and imaging, and these are pretty good markers of having fibrosis or cirrhosis, which is advanced liver disease. And what I want to point out is if you're Hispanic, you're 3 times more likely to have advanced liver disease after accounting for all of those other factors. This is a model that takes all those things into account. Uninsured, more than 2 times more likely. The other 2 factors, one, we would have expected past or current heavy alcohol use increases your risk, but obesity is a big problem in patients with HCV. It accelerates the disease and makes it more likely you have advanced disease at diagnosis. This is just another way of looking at it. This is using our CPRIT data. We have this paper under review, and I just want to mention that this is a model where we've taken into account all of these known factors. So we're equalizing alcohol use and other factors. But when you look at it, Hispanics versus non-Hispanic blacks, if they're normal weight, they're still more than 2 times more likely to have advanced liver disease. And it's somewhat attenuated versus whites. There are genetic risk factors that are at work here in Texas that actually accelerate it probably in Hispanics. The other point is this obesity with diabetes, it's 6 to 10 times more likely to have advanced liver disease if you're Hispanic compared to the other 2 groups. This is really frightening. So here's the conceptual model that we use to implement screening, and I want to mention this is from Glasgow and the NCI about 2 decades ago, and these are the pieces of the puzzle they say you need to implement to really make this work. So I just want to show you how we did this. Up in adoption, we had to go out and really engage the practices on multiple levels to get them to even care about this. And then we had to work with the electronic medical record. Believe me, in South Texas, that's not an easy thing, to try to support identifying people who need to be screened. Then we went to the community and patients and educated them about it so that the docs didn't have to do it. We put posters all over the practice to tell them that they need to be screened if they're baby boomers. And then we tried to integrate, there's this whole systems design. Who does it in the practice? Gets them to screen, follows it up, et cetera. It's not always the doc. So here's an example of the community outreach. We have it done by peers who are HCV infected and have been cured, as well as our community health workers who are bilingual. All of this is in both languages. And then we who are leading the program go out and talk to the community too. So the screening, we try to make it more efficient. There are ways to tie in the RNA test. Not everybody, by the way, you need to know, people clear the infection. Probably a third of people clear the infection without being treated. So you really have to do this second test to make sure that they are still infected. So we do that for the uninsured. With CPRIT funding, we're able to cover that for the uninsured. They will not do it. We know that without that. We have a case manager. These are very complicated steps patients have to follow, so they help them. Sometimes it takes a year or more. Patient education, have a mobile app I'll show you that we've developed for patients to learn about chronic infection. And then we teach the docs how to manage patients themselves. We have hepatologists teaching them about the new drugs. It's really straightforward in general, so they feel more comfortable actually prescribing and monitoring the patients. We have to stage patients, as I mentioned. We have to find out who has cirrhosis, who has worse disease, because we manage them differently. And then we have this neat thing where we have a hepatologist have office hours. Essentially, he sets aside a half an hour twice a week, and you can sign up as a primary care doc to come and present using a template that we've developed, present a case. It takes 5 to 10 minutes, and you come up with a management plan. What's great about having primary care do it, and I just want to give you a pitch, is that my hepatologist friends go, oh, I can treat that patient, ignoring that they have uncontrolled diabetes, uncontrolled hypertension, they're still drinking. They say, oh, I can treat anybody. But the primary care doc is a much more holistic way of looking at it.
Is that presented to be a telemedicine or something, or is that office hours?
Yeah, it's well, telemedicine, but this is provider to provider, not, yeah. Right. Here's the mobile app that's in Spanish and English. It has Teach Back that we basically want patients to understand it's not a stigmatizing disease, and there are a lot of things they can do. And then in terms of management, as I mentioned, it's a holistic approach. Patients who are uninsured actually are more likely to get treated in Texas than Medicaid because Medicaid is so rigid in terms of who they will cover with the expensive drugs. Only really advanced disease, in many ways too late. So we're able to go through the gauntlet, but it means a lot of paperwork. You have to apply to Medicaid, get turned down, and then you have to get more people to work together, and you have to apply to the drug companies, et cetera, et cetera. So you'll see when I give you the data, it takes a while to do all of that. And then finally, we have a registry, and I want to mention, we enter all of our chronic HCV patients into REDCap. We monitor every single step. We're able to use it to feed back to the practices how they're doing, and we're able to feed back to you how we're doing, and we're able to make papers out of it. So it's a really valuable resource to keep the registry. So how's our teleconsultation model going? This is for the uninsured. Over 200 people have been identified with chronic HCV. We've had the teleconsultation with about 70%. Of those, about 40% have started treatment. And what I want to emphasize is that once you started treatment, and a lot of those people haven't quite finished, there's a 12-week post-treatment RNA test to prove that you're cured. We have cured over 95% of people who get that 12-week point. Just like the specialists, we do the same. We're curing most of the people who go through treatment. So what's the challenges? Just briefly, lots of them. But, the EMR is a pain in the butt. The practices do not prioritize this because they don't get paid for it. If you do better with HCVs, with diabetes management, et cetera, you get more money. It's a quality measure. It's not a HEDIS measure, HCV. So it really hurts us. Payment for all of these things is an issue here. Imaging, case management, specialist consultation is only facilitated through this mechanism right now. And then we have to worry about the people that we have identified with advanced disease. They're cured, but they're still at risk for HCC. So that's another step that we have to integrate in. We have a dissemination grant that I just want to end with, happily from CPRIT, to put together a website to help practices learn from what we've done, give all of our tools, all of our webinars, and we have a, this is the website that I hope you'll look at. It's hepatitisc.com, and CPRIT is featured all over it. And this is our leadership panel from around the state of people who are mostly involved in primary care, who are helping us figure out how to make this most relevant to the primary care environment. This doesn't happen without a village. And this is a multidisciplinary group of people from UT Health and UT Southwestern that have been working on the big CPRIT grant that we've had. And it has been a pleasure to have this team involved. Thank you.
Congratulations. It's stunning results. It was for me. Any questions from members of the Oversight Committee? Dr. Turner, thank you very much. Fascinating work, and I'm sure I speak for everyone. Congratulations on having done such a terrific job.
It's been an honor to meet with you. Thank you.
One question. How many?
No, sorry.
No, you have to how many have been treated? What's the number? Did I miss that? I don't.
No. Of the uninsured, we have about 80. We have about 84 currently in treatment, and we have 72 cured. That's just the uninsured. We have a vast number of people who are insured up in Parkland, et cetera, and I would probably say a third of them at this point have been cured. And we're talking about, talking probably 400, 500 people there too.
Thank you.
Yep.
Did you say that, did you say that obesity and diabetes in a Hep C patient drives an increased incidence of hepatocellular carcinoma?
It really does. It drives a faster
Like
disease progression. Yes.
Well, faster disease progression. Does that drive incidence also? I just wondered two different things.
You know, we don't have enough cases of HCC to really say that. All we can say is it's a correlate of increased risk of HCC. So these people are at real risk. Okay. And the obesity epidemic is a major part of this problem of liver cancer in Texas.
Thank you.
Thanks.
Thank you, Dr. Turner. Chair recognizes Mr. Roberts to provide the Chief Executive Officer's report.
Unless you object, I would suggest that we move to an action item.
I don't.
Do you want to? Okay.
We got it.
All right. That being the case, I only have a few items to bring to your attention. The first one, as you know, is something that I always enjoy doing. I'd like to introduce to you one new staff member, Melanie Cleveland, our new executive assistant. You will, if you haven't already, be getting to know Melanie quite a bit, and if you're lucky, you get to interact with her more than me. On page 3-7 of the material is the report you see at each quarterly meeting indicating the amount of funds that are available, and if you adopt the recommendations coming to you today, you will have a balance at the end of the fiscal year in our grant award amount of a little under $3.1 million. So there are sufficient funds to cover the recommendations coming to you today. This would have been a little bit more meaningful if we had the meeting back on the 15th, but we've had two American Cancer Society Cancer Action Networks in this last week, which have been really great events. These are put on by Cam Scott and the Cancer Action Network. They have been very well attended, the two that we've had so far. We have one more in San Antonio on the 29th. Dr. Patel, if you can squeeze it in, it'd be great. I understand if you can't. But the one in Austin, Senator Watson spoke, and he's always, of course, very supportive of CPRIT and what we are doing. In Fort Worth, Representatives Nicole Collins and Giovanni Capriglione also spoke quite well. Mr. Montgomery had the opportunity to attend to these, and you may have some perspective you'd like to add.
Yeah, not much. I think they're terrific. And I notice Mr. Scott is in the audience. Thank you very much for arranging those events and for supporting CPRIT in the way you have.
Very quickly, the FY 2020 program priorities, they've now been mentioned in all three of the subcommittees. You will need to adopt these in the November meeting. Right now, it looks like we're largely headed towards adopting or recommending you adopt the 2019, but there is some tinkering, so please, think about those and be prepared at the subcommittee meetings to discuss whatever additional changes you'd like to have. The last item I have is summarized in the memo immediately behind my summary of it, regards the 2020 CPRIT conference. After considerable investigation by the staff, we decided that for a number of reasons, primarily to align the conference with the legislative cycle, to increase the ability to get greater competition among the hotels bidding for it, but perhaps most importantly, to allow us to repurpose the existing conference registration system for use in future conferences. This is key because in order to adopt or to modify the existing system would require us to do outsourcing that we estimate would cost us about $200,000 without a lot of time in order to get it up and running, because that would be the system that not only would be used for registration but would also be to provide your abstracts. And the $200,000 is probably more than our budget could accommodate at this point in time. With that, Mr. Montgomery, those are the items for my report.
Thank you, sir. Any questions on those items? Hearing none, I will take a moment to say something that is not on the agenda. One of the greatest parts of this job is to recognize the staff that have done a superior job. We are lucky to have such a terrific staff here at CPRIT. But it's also a great honor when those staff are recognized by outsiders. In July, Wayne Roberts was recognized as the Administrator of the Year by the Texas State Agency Business Administrators Association. It's one of the most prestigious awards given to state employees by that association. TSABA established the Administrator of the Year award to formally recognize state employees who have demonstrated outstanding leadership skills and who have made significant contributions to state agency business administration. We all know of Mr. Roberts' great efforts on behalf of CPRIT, but those are only the capstones of a 40-year career dedicated to working for the people of the state of Texas. I'm sure the entire Oversight Committee joins me in congratulating Mr. Roberts on this well-deserved award. Congratulations. That was not an invitation for you to speak again.
Well, but I am very, very quickly. Thank you. My name may be on that award, but for the last 5 years, that is an agency award. What we have done in the last 5 years is amazing, and it would not have been done without the fine staff that we have. I will take credit for the part of the award that preceded 2012, but from 2012, it is an agency award, and you folks share in that as well. But we have come a long way. But thank you for your kind words.
I think your statement is one of the best reasons for you receiving that award, giving the credit to others. In any case, I will ask the Secretary ensure that this recognition is officially recorded in the meeting minutes. Thank you, Mr. Roberts. I believe we now move on to the compliance certification, and I believe Mr. Burgess has an unavoidable conflict.
Compliance report.
Yeah, did I say compliance report?
Certification. Which happens at the board.
Whoops. Okay, compliance report. Mr. Burgess has a scheduling conflict, and Stephen Nance, CPRIT's Compliance Program Manager, will present the Chief Compliance Officer's report today. Mr. Nance.
Thank you. Good morning.
Good morning.
You will find the compliance report for the past quarter's activities behind tab 4. I'd like to briefly highlight 4 areas. Under our single audit tracking, related to our single audit determination form, as we've discussed in the past, the form is required to be submitted by our grantees for all active grants, indicating whether their institution expended more than $750,000 in grant funds for the fiscal year. Grantees will now complete one form for their institution on an annual basis and submit the form to CPRIT. This process change has been fully implemented now. Moving on to our on-site reviews, compliance staff have performed 16 on-site reviews for the current quarter. These are in-depth reviews that examine a grantee's financial and administrative operations, including subcontractor monitoring, procurement and contracting procedures, and other required reporting and support documentation to substantiate expenditures for reimbursement. Related to grantee trainings, CPRIT staff facilitated 2 new authorized signing official trainings for this past quarter. These trainings cover the grant reporting requirements, administrative rule changes, grant closeout, as well as a compliance overview that includes fraud, waste, and abuse. CPRIT staff also conducted a grant-specific training session at UT Southwestern Medical Center as part of their research administration demonstration training series. The training provided was designed specifically for UT Southwestern staff members that are working on CPRIT grants, and provided specific technical assistance related to their financial status reporting and other reporting and overall compliance as well. There were approximately 50 grantee staff in attendance to that training. And then finally, for the annual risk assessment, we have completed our annual grantee risk assessment for fiscal year 19. We had a more detailed discussion within our audit subcommittee, but just to remind you, the annual assessment considers 3 main factors to determine grantee risk. We measure entity maturity, financial exposure, and prior experience. The annual risk assessment assigns a priority ranking of 1, 2, or 3 to our grant recipients, and it's based on the results of the risk assessment, whether a grantee will receive either a desk or an on-site review, and also evaluate a grantee's compliance with their grant requirements. And that's all I have.
Thank you very much, Mr. Nance. Any questions from the Oversight Committee? Hearing none, I think we can now move on to the, thank you, Mr. Nance, for that wonderful and brief presentation. I believe we now move on to Mr. Wilson, for the, Dr. Wilson, pardon me, for the Chief Scientific Officer's report. Dr. Wilson.
Thank you. I want to briefly reprise the information that's in your Oversight Committee meeting book. It's section 5 of that book. And to observe that today we'll be talking about the Cycle 2 RFA results. I'll hold comment on that until we get to the grant recommendations. Upcoming in fiscal year 19, we've received, as indicated in Table 2 of that report, 401 applications for individual investigator research awards or targeted areas that have been identified as priorities for the CPRIT mission. These are undergoing review as we speak, and we'll be reporting back to you on those successful grants in February. Last week, the Cycle 2 of FY19 RFAs were announced. These included Core Facility Support Awards, the High Impact, High Risk Research Award, and you'll recall that we're bringing back the Early Translational Research Award mechanism to focus on academic institutions investigators who have discoveries that are ready for product development, but not yet de-risked to become competitive for commercialization. And then, in addition, we've announced the RFAs for Collaborative Action Program to reduce liver cancer mortality in Texas. We're excited about this project, which is a new strategy that CPRIT is taking on. Dr. Turner gave you a beautiful example of some of the resources that are currently in Texas to build on, and the idea here is to actually take those best practices and figure out ways to be better at implementing the goals that she talked about, as well as to distribute that information across the state. And in addition to those, of course, we've continued the recruitment award program and already have a group of recruitment applications that we'll be reviewing with our Scientific Review Council in the near future. If there are questions, happy to take those at this point, but also ready to move on to the proposed grant awards for the academic research program. And these are begin on page 12 of your grant award packet. There are 6 grant mechanisms that we'll be discussing, 51 awards, and a total of $112 million in proposed awards. This is, in my opinion, one of the most exciting group of applications that you'll be hearing for a number of reasons that I'll begin to highlight now. The first slate is for the High Impact, High Risk Award. It begins on page 13. These awards provide short-term funding to explore promising new directions. They support $200,000 in total cost over 2 years. There are 25 of these awards being recommended for a total of $4,998,000. I'll point out that 15 individual institutions are represented. I think this continues to demonstrate the impact of this particular mechanism of bringing a diverse group across the state of successful applicants. I won't discuss individually the awards, but I'll let you read through those at your leisure. Yes.
Very small thought, nothing action-wise, not really a question. On that page 13 in that table that begins all of the high risk, it says program at the priorities is the rightmost column, and it looks like only childhood priorities was listed and all the others are blank, and it maybe that's just sort of a table oversight in that filling of that thing. Are there other priorities? Or?
No, it's not an oversight. Those actually for childhood cancers directly address that priority. It turns out that among those 25, the other targeted areas of priorities, that is computational biology and prevention and hepatitis or HCC, were not represented.
Sorry, because I looked at Table 2 and I was thinking all those awards had all those, there's numbers of awards that had. Anyway, so you're saying there's someplace else on that Table 2 on page 13.
Yeah, so
looks like the total's up about 40 or 50 priority categories. Anyway.
So just to step back for a moment, thank you for helping to clarify Table 2. That's a summary of all 6 mechanisms that we'll be hearing today. I was speaking specifically about the high impact, high risk.
Got it. Thank you.
And you are correct. The Table 2 does demonstrate that the program priorities are nicely represented in this group of this award slate as a whole. It's my understanding that we're going to consider each of these 6 slates as a group, and so I'll continue with your permission to now talk about the Core Facility Support Awards that begin on page 16. These are large awards, up to $6 million over 5 years, and they're intended to support the acquisition of state-of-the-art equipment and technology that really isn't practical or feasible for an individual research lab to attain, and as a consequence are really great value for the cancer research community. They do not cover construction or major renovation of space. This is not supported as part of these awards. This is specifically for equipment and the technical expertise that makes this equipment available or this technology available. I'm excited to tell you that there are 10 core facility support awards that are being recommended today, over $49 million in funding. Because of the amount of funds that were available to the academic research awards this cycle, there was a need that the PIC recommended an 8% reduction in the budgets that were approved by our Scientific Review Council. This reduction, while not insignificant, I think is appropriately for this particular mechanism because there are other opportunities for making up that balance through both institutional and investigator chargebacks. If you will, I will make some brief comments about each one of these and be enthusiastic about any discussion that you may wish to pursue. But beginning on page 16 is an award for single-cell genomics core facility to MD Anderson. This core facility, like the majority of those that we're talking about today, bring exquisite new technology to answer fundamental questions that are actually new in cancer, and that is the heterogeneity that's now recognized among cancer tissues. They're no longer just cancer cells, but they're cancer cells plus many other cells that both determine the biology as well as treatment opportunities. It's also important to point out that this core facility, while based at MD Anderson, does serve researchers at Baylor, Rice, UT Health, UT Austin, UT San Antonio. And that's true of many of the core facilities that I'm going to mention today. The second, beginning on page 17, is the Children's Access to Regenerative Medicine in Texas, to Baylor College of Medicine. This is a core facility that will support the creation of cellular therapies. Think bone marrow stem cell transplants, think immunocellular therapies that are using specialized services at Texas Children's Hospital, and serving investigators at Baylor, MD Anderson, Children's Hospital San Antonio, UT Southwestern. Still on page 17 is the Protein Array and Analysis Core from the MD Anderson Cancer Center at Smithville. This is, again, a novel or an important expertise that's being provided to a group of medical centers across central Texas. On page 18, preclinical radiation core facility to UT Southwestern. This is providing the ability to conduct in cell and animal models the same kind of radiation therapy and imaging that's now part of the management of patients with cancer. And it's important because it brings in the physics and radiobiology needed to actually properly use such high-end equipment that will then reflect meaningfully in hopefully translating that kind of discovery to patients. On page 18, the Pediatric Cancer Data Core to University of Texas Southwestern Medical Center is a core that will develop the mechanisms to obtain from the electronic medical record and clinical trial results a compendium of data across pediatric cancers that will allow the analysis of this data for the research community. And I'll come back to this award in a moment because it relates to a second core facility award that I'll mention in just a few minutes. Again, on page 18, the Gulf Coast Consortium Centers for Comprehensive PK and PD formulation at Texas Southern University. This is the first award, CPRIT award to Texas Southern University, and it builds on a commitment of that institution to building an exquisite expertise in doing the assays required for preclinical assessment of new drugs. And it's important to point out that this success of this core facility is also reflecting the fact that the community came together with expertise from University of Houston College of Pharmacy, MD Anderson, and the Gulf Coast Consortium for Biomedical Science. That is, that expertise now is leveraging the commitment or the development of resources at Texas Southern University, and will have impact in terms of both individual investigator as well as startup company development of new therapeutics. On page 19 is the Pediatric Solid Tumor Comprehensive Data Resource Core at MD Anderson. I mentioned earlier the similar sounding core from UT Southwestern, and the important point is that these are complementary opportunities to build an important data resource for pediatric cancer, and the PIC has recommended, based on the Scientific Review Council's recommendation, that these two cores, before they actually implement a formal contract with CPRIT, begin to develop strategies to interact and synergize their opportunities, and have nominated the research program staff at CPRIT to oversee this process. Advanced multi-parameter cytometry and cell sorting core at Baylor College of Medicine, UT Health Science Center at Houston, Cancer Genomics core, and a small animal imaging core facility for cancer research at UT Dallas. Complete this group of core facilities.
Dr. Wilson, let me go back for just, if I may, to the two pediatric core facility grants. You mentioned that the PIC has recommended that the staff of CPRIT supervise the integration of those two awards. Is that right?
That is actually the recommendation. Specifically, the Scientific Review Council recognized that these two core facilities, which were reviewed in separate panels, were complementary and could have a greater impact if they actually worked together to identify strategies to build on each other's.
That's a different level of involvement for CPRIT staff, isn't it? I mean, isn't that a...
So if I may, so the recommendation was that the two core facilities, before the contract is formed, develop a strategy to implement what the Scientific Review Council has seen as an opportunity, and has nominated the research program staff to oversee this and to help shepherd it. This is not a different role that from the research staff has had in terms of overseeing the grant portfolio.
This is pre-contract.
It is pre-contract.
You're not going to be in there monitoring how they're doing every month or something like that as the grant continues in the next 5 years.
We will be monitoring the progress of the grant every year, as we do with all grants. With all of grants.
Right,
yeah.
right.
And the basis of that monitoring will be the goals and
Sure.
that are outlined in the contract.
Right. Okay. I understand. Thank you very much. Please.
If I can add one thing, like Dr. Wilson responded, there are times, and you'll hear it again later today, where the Review Council or the PIC will make recommendations about contingencies that need to be addressed prior to CPRIT executing the contract. Yeah. And so that is where CPRIT staff need to be more involved and ensure that that's done so that we can execute the contract.
Understood. Thank you, and sorry for the interruption, Dr. Wilson.
No, thank you.
Please continue.
I'd like now to move to the Multi-Investigator Research Award group, which are beginning on page 21. You'll recall that this mechanism is intended to integrate and to stimulate collaboration across disciplines and to increase the impact beyond what an individual research project can accomplish. These are large awards, up to $6 million over 4 years. There are 5 awards that are being recommended today. I want to emphasize that all 5 of these are highly translational projects. They build on exquisite discovery research, but the thrust and impact of these is really based on the fact that they interact directly with human patients, either in terms of patient tissues, annotated clinical resources, and clinical trials. So to begin, on page 21, the first is a program from the University of Texas Southwestern, led by Sean Morrison, a CPRIT scholar, metabolic enablers of melanoma progression. 3 highly integrated projects which are really designed to understand using patient material from melanoma patients to identify new strategies to prevent melanoma progression. The second on page 22 is from MD Anderson, Dr. Tainer, addressing BRCA answers from cancer interactome structures. Basically, what this is all about is that you recognize that there is a subset of breast cancer patients who are susceptible to breast cancer because of a genetically inherited BRCA mutation. It turns out that those tumors have a particular sensitivity to novel treatment that's been very successful. However, it's not totally successful. It's not curative, and there is progression and resistance. And so this is bringing together a highly skilled group to use clinical data to really understand and improve that therapy. On page 22 is another project from MD Anderson, led by a surgeon, Dr. Hunt, rational combination therapy options to reverse resistance in hormone receptor-positive breast cancer. This project builds on the expertise at MD Anderson and Baylor College of Medicine and patient data and patient resources to understand how to improve the response to hormonal therapy in patients with receptor-positive breast cancer. On page 23, a project from Baylor College of Medicine, predictive biomarkers and novel therapies for high-risk pediatric liver cancers. Dr. Lopez Terrada is leading this. Liver cancers in children have a dismal prognosis, and this project brings together collaborators at Baylor and UT San Antonio to address opportunities for better diagnostics and testing innovative therapeutics, including a very interesting immunotherapy strategy that will be evaluated. And then finally, on page 23, is a project from UT Southwestern led by Dr. Fu, a CPRIT scholar. Targeting tumor tissue increases DNA sensing to bridge innate and adaptive immunity. Basically, what this means is radiation therapy is a standard treatment for cancer, but it's interesting in that there has been evidence that there are combinations of radiation therapy plus immunotherapy have dramatic impact, but not in everyone. And so this is a very elegant study building on expertise in radiation therapy and immunology at UT Southwestern to understand that interaction and improve patient care. We've completed the grant proposals and are now moving to the recommendations for recruitment awards, and they begin on page 24 with established investigators. There are 2 established investigators that have been nominated for established investigator awards. The first is the Baylor College of Medicine, recruiting a Pen Wang from Georgia State University. Dr. Wang is a notable expert in carbohydrate chemistry. He brings expertise in understanding how carbohydrate decorating proteins actually impact cancer antigens for both treatment as well as diagnostics. The second is Dr. Henning, being recruited to University of Texas Southwestern from Max Planck Institute. Dr. Henning is an expert in MRI imaging and with specific application to the brain. On page 25 is the recruitment of Rising Star slate. One individual being recommended, Dr. Chen, to be recruited to Baylor College of Medicine from Dartmouth. Dr. Cheng is a system biologist who combines his additional expertise in molecular genetics and is focusing on questions related to predicting cancer immunotherapy success. And the final recruitment slate is listed on page 27, first-time tenure track. Recall that the aim here is to recruit the promising new emerging stars, if you will, of cancer research to pursue their first faculty appointment in Texas. 8 candidates are being recommended, and in the interest of time, I'll summarize this slate by noting that there are 2 candidates from Baylor College of Medicine, 1 from UT Austin, 2 from MD Anderson, and 3 from UT Southwestern. These recruits represent an incredibly impressive group from outstanding training programs: MIT, Rockefeller, Yale, Princeton, UC San Diego, Stanford, UC Berkeley, and the retention of a very promising pediatric cancer physician scientist at UT Southwestern. And I think it's fair to say that this group, as well as the history of first-time tenure track recruits, represent one of CPRIT's greatest impact and legacies in terms of looking into the future.
Thank you, Dr. Wilson. Any questions for Dr. Wilson on the 3 sets of recommendations he made? Members, Mr. Burgess provided a written compliance certification report to all Oversight Committee members 3 weeks ago. The report addresses all the proposed awards the Oversight Committee will consider today, including product development and prevention award recommendations. Are there any questions before I take up conflicts and the vote? Hearing none. Mr. Angelou has reported conflict of interest with 3 applications submitted by the University of Texas at Austin. Are there any other conflicts that members have not reported? Hearing none, members, you have the list of applications and grant amounts recommended by the PIC for the Academic Research Grant Awards. The PIC's recommendation will be approved if 2/3 of the Oversight Committee members present and able to vote approve the PIC's funding recommendations. Dr. Wilson presented 6 Academic Research Award slates. Rather than taking a separate vote on the different grant mechanisms constituting 51 grant recommendations, I will ask for a vote to approve all of the slates. We will take up the applications with identified conflicts of interest individually. If a member wants to consider any other award recommendation individually, please make a motion to do so now. Hearing none, we will take up the University of Texas Austin applications first. I will entertain a motion to approve the PIC's recommendation for the University of Texas at Austin grant applications RP 80690, RP1 80690, RP1 80880, and RR 180042.
So moved.
Second?
Second.
All in favor, vote aye.
Aye.
Hearing approval from 2/3 of the members present and able to vote, the motion carries. I note for the record Mr. Angelou did not vote on these recommendations. I will now entertain a motion to approve the PIC's recommendations for the remaining academic research awards for the following grant mechanisms: high impact Okay, I got them really primed. I'll tell you when. High Impact, High Risk Research Awards, Core Facility Support Awards, Multi-Investigator Research Awards, Recruitment of Established Investigators, Recruitment of Rising Stars, Recruitment of First-Time Tenure Track Faculty Members, and now you say?
Second.
All in favor?
Aye.
Thank you very much. Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. Members, I will entertain a motion delegating contract negotiating authority to the CEO of CPRIT, CEO and staff of CPRIT, and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
And a second?
Second.
All in favor? Doctor, congratulations to all those who may be present on the awards made. It looks like a fabulous slate. Dr. Wilson, I believe you are still up in the limelight for the Chief Scientific Officer's report.
Yeah, she can go.
Oops, sorry. Never mind. Yeah. Thank you very much, Dr. Wilson. Yeah, it's okay. The chair's right on top of this. Chair recognizes Mr. Lang to introduce the Program Integration Committee's grant award recommendations for the product development research grants. Mr. Lang, good to see you again.
Thank you, Mr. Montgomery. There we go. In tab 7 of your book is the product development report. However, we've basically put the same information in a PowerPoint format just so we can present it more easily here. Really just going to talk about 3 things today. First of all, the program priorities, which we've already addressed, updates on our current active product development award cycles, and lastly, just an overview of our future plan cycles. As was noted earlier, the current program priorities are being planned to be utilized again in fiscal year 19 as we move forward. As Mr. Roberts noted earlier, that'll be a topic of discussion at the next Oversight Committee meeting. Slide 4 just shows the schedule, what has progressed on cycle 18-2. This is the one that's about to close. We received a total of 20 applicants. 10 were selected for peer review. 6 of those then went forward into the due diligence process. Of those 6, 3 were recommended for OC approval. I'll be discussing those after the report. 2 were deferred action, meaning that the Product Development Review Committee felt that these were attractive and interesting investment opportunities. However, there was information gaps that they wanted filled before they could vote to move them forward. So we've been in touch with the companies. They're addressing those information gaps and possibly have those available for your review and approval at the next Oversight Committee meeting. And lastly, the 6th one was not recommended to move forward. So as I present those today, that'll conclude our work on 18-2. We've also opened review cycle, RFA cycle 19-1. That's just getting started. What's noteworthy about that is this is the first time that we've afforded an RFA for the SEED awards. You may recall at a prior meeting, the Oversight Committee recommended the approval of a new mechanism, basically a scaled-down mechanism of our current product development awards, specifically focused on earlier stage companies and company formation. These have a cap of $3 million as opposed to the $20 million cap of our current awards. So this RFA, so we've historically only had 2 RFAs for Texas and relocating companies. Now we've added the 3rd RFA for the SEED program. We had 5 applicants for the Texas application and for Texas companies, 9 for relocations. That's a total of 14. However, we had 27 SEED applicants. This significantly exceeds even our optimistic forecast as to how many applications we would receive for the SEED program. This clearly shows that the SEED program addresses an unmet funding need in the development process for these early stage companies. So we're very happy to see an enthusiastic response from the development community for the SEED program. And obviously they'll be moving through the process in parallel to the product development applicants. So those of the 41 companies that are ultimately recommended for approval, we would be presenting those here in February. So just getting started on 19.1, planning for future years. For fiscal year 19, we plan 2 cycles, again with 3 RFAs, Texas, relocation, and seed. 19.1, as I noted, is starting. 19.2 will start mid-year and conclude about August of next year. And then in fiscal years 20 and 21, as budgets decline for CPRIT, we're planning 1 cycle in each of those. Obviously, if there's changes in the budget, we can adjust that, but 1 cycle plan for each of those years. Yes, Dr. Rice.
Quick question I hadn't thought about. The review process, the review process for those 3 million seed applications seems like it would be substantially less complicated than the larger ones historically, which have, IP and due diligence and all kinds of other kinds of things. Is the schedule the same for them? Is the schedule to have an evaluation and review of the seed applications the same as the sounded that it was the same as for the bigger applications? I'm just trying to ask the question if it's simple enough where that could be accelerated.
Two comments there. First off, the seed applications are not demonstrably less complicated. They are less. There's less information. They're just in an earlier stage of development, so there's simply less information available about these projects. However, there's still a fairly significant amount of work to be reviewed. So the process is substantially similar to our current process. But I'd say kind of 2/3, 3/4 as much work per applicant. But they're going to go through the same process in the same sequence, in the same timeline, and that was necessary in order to to comply with both CPRIT policy and minimize the budgetary impact of the new program.
Thank you.
So we're using the same reviewers, same review process. That really concludes my discussion about the program. Is there any? I'll stop here and ask if there's any questions. No. Okay. All right. In that case, I'll turn my attention to the second topic, which is the 3 awards that we're here to request approval on. I'll talk about each of these briefly, and then allow you to ask any questions that you might have. I'll talk about 2 companies in parallel: Formation Biologics and Cerex. The reason is they're both at substantially similar stages of development, substantially similar histories. Both of these companies are developing novel cancer therapeutics. They're both Texas-based. They're both prior awardees. In both cases, CPRIT funded late-stage preclinical development, IND studies, and lastly, phase 1 clinical studies. So in both cases, the companies completed their phase 1 clinical studies with successful results. These results were encouraging. They were the subject of. They were provided back to us for their second application, reviewed by our reviewers, and determined that these.
Sorry, members, in the award book, these matters start at page 141.
Thank you. Sorry for.
They're like flipping around.
Yeah. Yeah, there's the award book and the program book. Sorry. So in any case, the results of both phase 1 studies were presented to us as part of their applications, and the reviewers felt that these results were encouraging, and that further development and further investment was required, was indicated. Both were scored very highly, reviewed by the PDRC, by the reviewers, and by the PDRC, and by the PIC. So Cerex is developing a fenteneride therapy for specifically aimed at T-cell lymphoma patients, and Formation Biologics is developing antibody drug conjugates. We've talked about these before. They're the, quote, guided missiles. The antibody homes in on, latches into the cancer cell and brings with it a drug, a toxin that destroys a cancer cell, so they're highly specific. And Formation Biologics therapy is addressing multiple cancers. The third company is Carisso. They're also a therapeutics company. They're developing a drug. This was developed, initially researched and initially developed MD Anderson, but for a very different indication. Most of our therapeutics companies are developing drugs to treat cancer. Carisso is developing a drug to treat the side effects of chemotherapy, which treats cancer. Chemotherapies are obviously very toxic chemicals. They have very significant side effects, including neurological side effects. Two main side effects of neurological side effects of chemotherapy are neuropathy, which is degradation in the peripheral nervous system. If you've ever, gotten the, banged your elbow and gotten the funny bone, or your arm is tingling or goes numb, that's a very brief, short-term manifestation of neuropathy. Some chemotherapy patients get that on a chronic, significant basis and becomes very debilitating, and often limits the amount of chemotherapy that they're able to endure. So that's the peripheral nervous system. Chemotherapy also addresses the central nervous system and causes cognitive dysfunction. Kind of the colloquial term for this is chemo brain, meaning that patients have cognitive deficit because of chemotherapy. It's been equated feeling in a fog, being like you're drunk, etc. But these patients don't have full use of their cognitive functions because of chemotherapy. Again, it's a limiter. Some patients aren't able to receive the full course of chemotherapy. No good therapies for either of these side effects today. So Carisso's developing a small molecule therapy for this, and they're basically at the stage where we originally funded formation and Cirex. We will be funding the late-stage preclinical work, IND-enabling studies, and the early phase 1, phase 2 clinical studies. So that's a quick summary. I'll stop here and ask if there's any questions.
I think you skated. Let's see. Good job. Thanks. Turning to, if there are no questions for Mr. Lang, which I presume there are not, turning to the Product Development Research Award recommendation, I remind the members that Mr. Burgess has certified compliance of the Product Development Award process. It is my understanding that no member has reported a conflict of interest with the product development recommendations. Award recommendations. Are there any conflicts of interest that members have not reported? Seeing none, I will entertain a motion to approve the PIC's recommendation for the 3 Product Development Research Awards.
So moved. Second.
All in favor?
Aye.
Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. I will entertain a motion delegating contract negotiation authority to the CEO of CPRIT staff, CEO and CPRIT staff, and to authorize the CEO to sign the contract on behalf of CPRIT.
So moved.
Second?
Second.
All in favor?
Aye.
The motion carries. It is approved unanimously. Let's see. Members, Mr. Roberts notified the board on August 10th that he seeks authority to disperse grant of funds in advance to the 3 companies we have just approved for awards. Are there any questions for Mr. Roberts regarding this request? Hearing none, I will entertain a motion that pursuant to the General Appropriations Act, Article 9, Section 4.03A, to authorize CPRIT to disperse grant funds via advance payments to DP18040, DP1800042, and DP1800048 upon execution of the award contracts and successful completion of tranches.
So moved.
All in favor? Sorry, did I get a second? Second. All in favor?
Aye.
Motion carries.
Thank you, members.
Thank you very much, Mr. Lang. Pleasure to see you again, Dr. Garcia. The Chair recognizes Dr. Garcia to provide the Chief Prevention and Communication Officer's report.
Okay, we'll start under tab 7 in your main book with a very brief report from the prevention program. I will be presenting momentarily the 10 awards for cycle 18.2. You can see on page 272, cycle for fiscal year 19.1 is currently underway. Those applications are due September 5th and will come to you in February. I will need approval for 19.2 for the RFA schedule and release of those. They're scheduled to to be released, and submissions due in February. So you'll see listed below that table the 4 RFAs that are proposed for the 19-2 cycle. And I believe you'll take up that motion after the grant awards, looking at the agenda. In terms of other activities for the prevention program, we're in the final proofing stages for the 2018 Texas Cancer Plan. So that will be out shortly. We will post it on our website first, and then later, probably in September, print hard copies. So that is my report.
Could you send copies of that, to us?
Absolutely.
That'd be great.
Yeah.
That'd be great. I know it's a fault, but I don't check the website every single day.
No, but we're going to post it first and print in September, so we will send it
Whenever it's done.
as soon
I'd love
as
to
it's
see a
done.
copy. Thank you.
So if there are no questions on just the prevention program report, I can turn to the
Please
10
do.
award recommendations. And those are in your other book. They start on page 92 with a memo.
I know what I'd do if we ever went in exact sequence.
So for cycle 18-2, the PIC is recommending 10 projects totaling $14.3 million. They're going to be presented in 3 different slates: tobacco control and lung cancer screening, the expansion of preventive services to rural and medically underserved populations, and evidence-based cancer prevention services. The PRC and the PIC are recommending budget cuts of 10.02% in order to fund all of the projects that we wanted to fund this cycle and use up the entire amount of money we had available. It was a very competitive cycle, and you can see that from the very good scores of the projects that we're presenting. But even with that, we wanted to reduce the budget to get in as many as possible. We also had one application come in for the dissemination mechanism that is reviewed quarterly, but the PRC was not recommending that for approval. So I will start and just give you a very quick overview of the 10 projects. Under the tobacco control and lung cancer screening, we're recommending 2 projects for $2.6 million. The first one is to Janice Blaylock at MD Anderson. And this is a new project that focuses on smoking cessation in pregnant women. They're going to be working in 12 clinics in 7 Northeast Texas counties. And Northeast Texas has a very high rate of smoking. And this is really an issue in pregnant women. Actually, the CDC put out a report in March that showed that 1 in 14 pregnant women smoke. And so there's a lot of implications for not just infant mortality, but mortality of these women as well. So tobacco cessation is a big issue.
Wow.
The next project is to Dr. Ramirez at University of Texas Health Science Center, San Antonio. And this project builds on one that was previously funded for cessation and treatment. And the plans here are to integrate cessation and treatment into routine care. So in addition to providing these services, they're also going to provide training to primary care providers and the cancer team on new protocols and appropriate referrals. The next slate is, there's 2 projects in that slate requesting $4.1 million. And it is the expansion of cancer prevention services to rural and medically underserved populations. So we started requiring with renewal applications that they have some sort of expansion to rural and medically underserved areas, and if they're already in those areas, some expansion of the type of service that they're providing. So the first one is to Dr. Jane at University of Texas Southwestern Medical Center. And it is a liver cancer prevention project. We'll be screening baby boomers. There'll be patient and provider education. And the expansion is from 9 counties to 18 counties. And they're going to be working with 4 federally qualified health clinics in South Texas and a healthcare system in El Paso.
Is that related to the work that Dr. Turner is doing?
Yes, similar work that's being done.
Okay.
The next project is to Dr. Vernon at University of Texas Health Science Center, Houston. And this project is expanding a project that was started in the Houston area for HPV vaccination in pediatric clinics. And she's taking that project to Children's Hospital Clinical Network in San Antonio. The next slate, there are 6 projects requesting $7.46 million. There are 6 projects, 2 on liver, 2 on HPV, 1 breast, and 1 for the prevention of obesity-related cancers. So the first one is to Dr. Schick at the University of Texas Health Science Center in Houston for hepatitis B and C screening. And this one is targeting a homeless population. And the homeless population here has high rates of hepatitis B and C. It's a very innovative project. They're going to partner with a permanent supportive care provider and a federally qualified health care center that focuses on health care for the homeless. So there'll be a lot of education, risk reduction strategies, and navigation to treatment in addition to the screening for these viruses. The next project is to Patricia Gallegos at Centro San Vicente, and they're going to be doing hepatitis B and C screening, education, community health worker outreach, provider training to the residents in El Paso County and 3 very rural counties in West Texas, Culberson, Presidio, and Brewster counties. The next project to Allison Grimes, University of Texas Health Science Center, San Antonio. This project's going to focus on HPV vaccination of childhood cancer survivors. And these are cancer patients, survivors who are seen at 5 regional pediatric institutions. And those 5 institutions have a very large catchment area. They cover 113 counties. They expect there will be about 1,200 patients who would be age eligible in those counties. In addition, they're also including staff and provider training. The next project to Dr. Berenson at University of Texas Medical Center at Galveston is going to deliver HPV vaccination screening services to through 2 UTMB clinics, one in McAllen and one in Galveston. They'll also be educating the community leaders and providers and trying to get them to increase the recommendations for getting these vaccines.
Dr. Garcia, excuse me.
Yes, sir.
So far, so we're on page 98. I think that many of the ones that you previously mentioned relate to HPV and HCC, right? And I just wonder, is there sufficient coordination? We're not just sending everybody out on their own.
When you look at the geography of these, they're covering different regions, different areas.
Unquestionably,
of
right?
state.
They all know of each other as well,
and
right?
some of these are really focusing on very specific populations. populations like childhood cancer survivors. So others may be looking at a pediatric population, but not necessarily childhood cancer survivors, or looking at this homeless population. So they're targeting, in some cases, different populations as well. But to your point, as we get these applications in, they don't know who's applying for what, but when we see the opportunity for coordination and collaboration, we definitely put them together.
Okay, great. I didn't mean we were duplicating. I meant, do they know of each other and they are using whatever tools they can to coordinate?
What they know when they're applying is we have maps on our website, and they can see where there are projects covering certain cancer types. They don't necessarily know who's covering those, but if they call us, we will definitely, give them that information, because the counties are not listed on our website as who's covering what counties, but they do have a lot of information, and they're being very strategic now and looking at the areas where we don't have projects in certain types and applying, that way, because they know they will be more competitive.
Okay, thank you. Please continue.
There's one breast cancer project to Dr. Simon Craddock Lee at the University of Texas Southwestern Medical Center. And this has been a previously funded, very successful project serving 35 counties in North Texas. They have a really vast network of providers that they work with, really trying to link the under and uninsured to local providers. And one of the new features that they're doing with this project is they're going to be looking at the presence of screening facilities in this 35 county area and looking at actually trying to track actual use of those facilities. So that's just a new added feature to that project that will be very interesting, I think. The last project is to Dr. Salinas at Texas Tech Health Science Center, El Paso. And this one is on the prevention of obesity-related cancers, so it's a different project for us. There'll be a lot of public education that goes along with this project, counseling training for students, for medical students, nurses, and others, and a lot of work in the community to try and build sustainable programs. So there'll be things like walking and exercise programs, group programs at local parks, cooking classes, other kinds of strategies to really get at reducing obesity, and they will actually be doing some biometrics to see the impact. They'll be tracking about 600 people and looking at things like BMI and weight and how that changes over time. So those are our 10 projects. I think they have a very broad geographic reach. They provide a wide range of services and really are targeting some very vulnerable populations. I neglected to mention, on the next page you'll see the chart with the priorities. They do address one or all of the 3 priorities. And we provided a map of just these 10 recommended projects and their geographic coverage.
Great.
Which is on page, what is that, 101? And then after that on 102 is a map with a cumulative of all projects over time.
That's terrific. Thank you very much. Those maps are extremely helpful.
Quite welcome.
Will you help us? I'm sorry, on page 101, I was just trying to see, that's the map, that relates to just the ones we're
just the 10
today.
That's today.
Yes.
And regions have, I guess, up to 3 to 4 projects some regions do. Of
Right.
those 10 today.
For example, if you look at El Paso, there's 2 liver cancer projects there, 1 HPV and 1 obesity that touch the El Paso County.
Got it. Thank you.
Members, any questions for Dr. Garcia? I remind the members that Mr. Burgess has certified compliance of the prevention award process. It is my understanding that Mr. Margot has reported a conflict of interest with one prevention award recommendation. Are there any conflicts of interest that members have not reported? Hearing none, you have the application and grant amounts recommended by the PIC for prevention grant awards. The Oversight Committee will ratify the PIC's recommendations if 2/3 of the members present and able to vote approve the PIC's funding recommendation. We will take up the application with the identified conflict of interest individually. If a member wants to consider any other award recommendation individually, please make a motion to do so now. Hearing none, we will take up the application with the identified conflict of interest first. I will entertain a motion to approve the PIC's recommendation for PP1 80091. All in favor? Aye. Aye. Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. I note for the record that Mr. Margot did not vote on that recommendation. I will now entertain a motion to approve the PIC's recommendation for the following mechanisms: tobacco control and lung cancer screening, expansion of cancer prevention services to rural and medically underserved populations, and evidence-based cancer prevention services.
So moved. Second.
All in favor?
Aye.
Any opposed? Hearing none. Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. I will entertain a motion to, delegating contract negotiation authority to the CEO and staff of CPRIT and to authorize the CEO to sign the contract on behalf of CPRIT.
So moved. Second.
All in favor?
Aye.
Motion carries. Dr. Garcia has presented the proposed timeline and prevention program RFAs CPRIT will release for the second cycle of FY 2019. I will entertain a motion approving the proposed timeline and prevention program RFAs for the second cycle of FY 2019.
So moved.
Second? All in favor?
Aye.
Motion carries. Dr. Garcia, do you have a communication program report for us?
I do. Back on the main book, tab 7, page 3. Very brief. I just wanted to add my thanks to ACS CAN for the forums that they've put on already and for highlighting prevention in this series of forums. Those have really resulted in some great attendance and audience, and I'm hoping the word is getting out. We did have a very nice media story coming from the Austin event. KXAN picked up one of our grantees, Dorothy Gibbons from the Rose. So that was a very nice clip. Other activities under communications, we're working with BioHouston and THBI. They're planning an event in October in Houston to get CEOs from CPRIT's product development companies together with area legislators. So it's really an event that is under the control of THBI and BioHouston. We're just helping them as they need. Also, in conjunction with the San Antonio ACS CAN Forum, we're preparing for a public announcement of the initiative Dr. Wilson talked about, the liver cancer CAP program. And so we'll be doing a press release and some interviews and creating some communications pieces with those interviews following that announcement. In a couple of other things we've worked on, and we redesigned the achievements report. We now call it a momentum report, and I believe we have copies to hand out if they're not already at your desks. No?
We'll pass those out when we go into the executive session.
Okay, very good. And also a redesign of a one-page that Wayne uses pretty exclusively when he does his visits. But what we did was we have a lot of statistics in our momentum report, and what we did this time is we have a lot of the statistics that are still in there, but we really wanted to highlight a story from each of the programs. So we'll be putting in We're not sure quite what frequency we will change those stories out, but it won't be every quarter. We will change the statistics every quarter. And we're also working very closely with our IT team right now on the website, the new website, and we hope to have a release of that before the end of the calendar year, probably late November. But there's a lot of work going into that right now and getting it ready. That is my communications report.
Thank you very much. Any questions? Let's see. I think we have a few. Thank you very much, Dr. Garcia. Excellent report. Mr. Roberts will present appointments to the Scientific Research and Prevention Program Review panels. Mr. Roberts.
Yes, members, I did appoint 4 experts to the Scientific Research and Prevention Programs Committees. Our statute requires the appointments be approved by you. The Nominations Subcommittee discussed the appointments at its meeting on August 10th and recommends that the OC vote to approve the appointments. The bios are in your meeting books. I request approval.
I will entertain a motion to approve the Scientific Research and Prevention Program Committee appointments.
So moved.
All in favor?
Aye.
Aye. The motion carries. Next, Mr. Roberts has appointments to the Clinical Trials Advisory Committee. Mr. Roberts.
Yes, thank you. At the May Oversight Committee meeting, you adopted the charter and six academic research initial appointments to the Clinical Trials Advisory Committee. At that time, I mentioned I'd like to add representatives from the Product Development Program to the committee for a current total membership of going to 8. The 2 appointments have extensive experience with clinical trials and have been reviewed by the Nominations Subcommittee. I request that you appoint these 2 members to the committee.
Any questions? Hearing none, is there a motion to approve the Clinical Trials Advisory Committee appointments?
So moved.
Second. All in favor?
Aye.
Motion carries. Chair recognizes Mr. Roberts to present the FY 2019 honoraria policy. Mr. Roberts.
The recommended peer review honoraria policy must be approved annually by you. The staff recommends reapproving the 2018 policy as the 2019 honorary policy. There are no changes.
Any questions? Is there a motion to approve the FY 2019 honoraria policy?
So moved. Second.
All in favor?
Aye.
Thank you. The motion carries. Chair recognizes Mr. Roberts to present the Health and Safety Code Section 102.1062 waivers for FY 2019. Mr. Roberts.
Thank you, members. I request readoption of 5 participation waivers for 4 individuals and a general peer review waiver, all due to specified activities. The 4 individuals are staff members Don Brandy, Becky Garcia, PIC member John Hellerstadt, and OC member Will Montgomery. These waivers are identical to those you've approved previously and can be revoked by the Oversight Committee at any time if a violation or other reason develops during the fiscal year. I request approval.
Any questions? Is there a motion to, I have to note that since I probably can't vote on my own waiver of conflicts of interest, I will not vote, but is there a motion to approve the 5 proposed Health and Safety Code Section 102.1062 waivers?
So moved.
Second. All in favor?
Aye.
Motion carries. I note that I did not vote on my own waiver.
And I counted the votes.
Okay. Thank you. Thank you. Members, because of our time, let's see, we are going to go to item 16 on the agenda. I know this is a great disappointment that we are postponing the auditor's report, but we are going to take up the internal auditor report after we have closed session. So we are jumping to item 16 on the agenda, which is amendments to 25 TAC Chapters 701 and 703. And Chair recognizes Ms. Eckel. Welcome, Ms. Eckel, to discuss proposed administrative rule changes. Ms. Eckel.
Good morning. I know it's not a disappointment to get to the rules sooner.
Right,
than you
exactly.
thought you would.
Right.
Just real quickly, I'll start with the final order, which proposes for adoption the rules from the May Oversight Committee meeting. They were published in the Texas Register on June 1st. We didn't get any comments, so they'll be proposed for adoption the same way you saw them back in May. We do have a new set of new proposed rules. It's really just one change that impacts several rules within Chapter 703, and it would allow grantees to file required reports the following business day if the due date falls on a weekend or a federal holiday. Again, just one change impacting several rules. I did want to point out there's a slight process change for the new proposed rules. The governor's office sent a memo to agencies in June asking them to submit proposed rules to their office before submitting them for publication in the Texas Register. Ms. Doyle submitted the rules on July 27th, and the governor's office did not have any comments for those rules. So otherwise, the process remains the same. They'll be published in the Texas Register, open for public comment, and brought back at the November meeting. And that's all I have.
Members, is there a motion to, any questions? Pardon me? And any questions for Ms. Eckel? Hearing none. Members, is there a motion to approve the final order adopting rule changes to Texas Administrative Code Chapter 703, 701, and 703?
So moved. Second.
All in favor?
Aye.
Any opposed? Motion carries. Is there a motion to approve the publication of the proposed changes to Texas Administrative Code Chapter 703 in the Texas Register?
So moved. Second.
All in favor?
Aye.
Hearing no dissents, the motion carries. Now, Chair recognizes Ms. Doyle to discuss proposed changes to the Oversight Committee bylaws and Code of Conduct.
Members, we are making one change to the Code of Conduct. It's part of the Oversight Committee bylaws. It's on page 1412 in your packet. You can see we are deleting section G under Article 5. We are deleting this because the legislature removed the requirement that Oversight Committee members post their political contributions on CPRIT's website. So we are updating our Code of Conduct to make it consistent with the law. This was presented to the Board Governance Subcommittee, and they recommend that the Oversight Committee approve the change.
We're in favor of compliance with the law. Members, is there a motion to approve the proposed changes to the Oversight Committee bylaws and Code of Conduct?
So moved. Second.
All in favor?
Aye.
Motion carries. Ms. McConnell, the Chief Operating Officer report, I believe, is up.
Good morning. So my report is under tab 15. I'll just highlight that the legislative appropriations request for 2020 and 2021 was confirmed by the Audit Subcommittee at their special meeting on July 26th, that it was confirmed that the draft LAR was consistent with the items that were discussed by the Oversight Committee at the May 16th, 2018 meeting. And this includes two exceptional items. One was for $164 million in general revenue, and the other was for an additional full-time equivalent for a new IT staff position. This LAR was submitted to the Governor's Office and the LBB on August 3rd, which was our due date. We will have our joint budget hearing with both of those offices on September 4th, right after Labor Day. The other thing I'd like to highlight is the discussion in my memo on the FY 2019 operating budget. I noted that we have adjusted the operating budget from what was appropriated by $234,509. This was an adjustment moving money from grant review and award operations into indirect administration. The reason for this are additional IT needs for projects that have come out of the information security audit. And so we have that adjustment. We also need additional funds, which would require moving money from the research grant award line item, a little bit more than $500,000, almost $550,000. I noted there on the budget document. And we discussed this with the audit subcommittee, and there were no issues, but before we send the letter to the LBB, because it will require LBB approval to make this a final adjustment of the $547,000, just wanted to make sure there wasn't any objection from any of the Oversight Committee members one last time. It does not require a vote, but we just want to make sure there's not an objection.
Hearing none, I declare there are none.
Okay. Thank you. That's all I have, unless you have questions.
Ms. McConnell, I believe you are also the next agenda item, and that is the recommended contract approvals.
Yes. So there are 3 contracts. One is the communication service contract. This was issued under a new RFP this year. This will be for FY19, and the award was made to Han Public Communications for $149,975. The other 2 are contract renewals. One is to the Perriman Group for $150,000 to perform an economic assessment of the cost of cancer. And the other one is the renewal with Weaver and Tidwell for $171,000 to provide internal audit services in 2019.
Any questions on those contracts from the Oversight Committee? Members, is there a motion to approve contracts with Han Public Communication, the Perryman Group, and Weaver and Tidwell?
So moved.
Second?
Second.
All in favor? Aye, the motion carries. Thank you very much, Ms. McConnell. We move down close to the end. CPRIT's bylaws require the Oversight Committee to vote to approve as chair, to approve a chair of each subcommittee. Since Amy Mitchell's resignation from the Oversight Committee, the Board Governance Subcommittee is without a chair. The Board Governance Subcommittee met and unanimously proposed that the Oversight Committee elect Dr. Mahendra Patel as chair of the Board Governance Subcommittee. Let me say in advance, thank you very much for agreeing, Dr. Patel. Are there any questions on this item? Members, is there a motion to approve Dr. Patel as chair of the Board Governance Subcommittee?
So moved.
Second?
Second.
All in favor?
Aye.
Motion carries. Item 21, compliance investigation. Right, not taken up. Now we have to go back to closed session. Oh, yeah, right. Members, the next regular Oversight Committee meeting will occur on November 28th. Calendar for fiscal year 2019 meeting dates and subcommittee meetings is in your packet behind tab 17. While we hope to have more members appointed, it is critically important for each one of us to look at the schedule. I know Mayor Margot needs to make some changes because of his responsibility. Please look at that calendar and report in any conflicts you have so that we can take care of them now and we don't have to scramble next year. So I know you all take up your homework assignments with zeal on Friday night, so there's not done Sunday night. And now we move to a closed session, which I need.
No, it's not to us.
Not yet?
To item 15. We'll do mostly of it.
Oh, well, take that back. We will move to closed session around noon. Ms. Martin, I'm sorry to jumble you around. However, we have the internal auditor report. And while we all love auditing, not quite as much as you do, I'd remind you that you are the only thing standing between us and lunch. I'm kidding.
Okay.
Please, Ms. Martin, don't let me.
Page 12.
Chair, let me just say the chair recognizes Ms. Martin to present the status update on internal audit activities and to present one internal audit report as well as the follow-up reports for 3 previous audits with findings. After she completes the report, the Oversight Oversight Committee will move into closed session so that Ms. Martin may present the follow-up procedures over the information security audit. Ms. Martin.
Thank you. Page 12-1 in your book. So as internal audit, we have completed the internal audit plan for fiscal 2018. The audit over communications is complete, and it starts at page 12-14 or 12-7 in your book. I'll turn you to page 12-14. The completion of this internal audit over the coverage was a satisfactory internal audit report. We had 5 findings as part of this audit, only 1 high-risk finding as part of the audit, and that finding had to do with some criteria that is state regulated criteria the website needed to include. The management of CPRIT had already identified these areas, and we're in the process of working on incorporating that criteria in the website at the time of our audit. The other 4 findings, 3 are moderate, had to do with approvals and validation prior to movement of information, and we are looking for formal written documentation of those types of approvals, whether it's on the website or through social media. And then the last 2 items have to do with the segregation of duties in a particular mail serve application and the timeliness of the achievement report going to the CEO for his review and approval. And so all of those findings are formalities in documentation and the process, and the communication staff is well under their way through their management responses and completing the changes necessary from that audit. That audit is completed, and you have the full audit report starting at page 12-7. The other 2 audits moving on, the other 2 audits of the year were deferred to 2019, and you'll see them on the 2019 internal audit plan. We also performed follow-up procedures for any open findings that remained. We'll talk about the IT security follow-up procedures separately. We performed follow-up procedures over the procurement internal audit, which is presented on page 12-27 of your package. There is 1 remaining partially closed finding for some timeliness of reviews that should occur within 30 days. That is very low risk at this point, and so everything else closed. And then on the pre-award grant audit, there were 3 findings previously. We followed up on all 3 of those findings. They are all closed. That's presented on page 1242 of your package. All of our internal audits for fiscal 2018 are complete. All have been presented to the audit subcommittee, and all are now presented to you as the oversight committee. Moving on through our plan, we did conduct an annual risk assessment update. This is the year 3 more thorough risk assessment update. Mr. Montgomery participated. That was conducted on July 30th. The results of that risk assessment update are presented on page 12-4. There are 27 significant processes across the agency that would be available to consider for internal audit. You'll see that there are 11 considered high risk through the self-assessment. And in the 3rd column, as presented on page 12-4, you'll see the amount of coverage that we as internal audit have had over the last 4 years through all of our internal audits. We began internal audits in 2016. The audits conducted in 2015 as presented were the predecessor, and 14 were the predecessor auditors, for which we conducted follow-up procedures to ensure that any prior findings had closed prior to commencing in 2016. We do have 2 audits on the list that are recommended to be added to the 2019 internal audit plan, and those are marked in blue, line 13, budget and planning, and line 15, state reporting requirements. You'll also notice that information security and IT general computer controls that were deferred from the fiscal 2018 plan is not recommended to be audited in this next fiscal year as we continue to work with IT to close out the prior audit findings and for them to be able to focus on other priorities. So as presented at page 12-5 is the internal audit plan that I'm presenting today for fiscal 2019 for your consideration. We've had deliberations at the audit subcommittee around this plan. As I mentioned, Mr. Montgomery participated in our management discussions around this plan, and we have a reduced plan for really only conducting 2 full internal audits next year. I think the risk assessment coverage shows that a lot of the process areas have been touched, and what you don't see there is that for the majority of those, we have a strong internal audit rating on those. So as internal audit, I'm very comfortable with the 2 audits proposed for next year, and then we'll readdress the plans going forward with management. So in fiscal 19 on page 12-5, you'll see state reporting and budgeting and planning as our 2 full internal audits for consideration. In addition to that, our audit team will be performing follow-up procedures on 4 internal audits that still have some open findings. The new audits for communication and the post-award grant audit that was done in this fiscal year, and then the remaining open findings for procurement and information security. You'll also see a 5th audit there that was performed by the State Auditor's Office over performance measures, where we as internal audit will perform the follow-up procedures to ensure that the action items committed and the remediation is complete for that SAO audit. And so the audit plan, as presented on page 12-5, is for your consideration today. This audit plan is also incorporated in the annual internal audit report that I have to prepare and present to you according to the State Auditor's Office procedures. That report is presented to you and starts on page 12-53 of your report. This report is not due until November, but it is prepared, ready, and complete. All of the components comply with the SAO's requirements, and I'll point you to page 12-60, where the internal audit plan that I just presented to you is also reflected on page 12-60. So this communicates the audit procedures that are planned for fiscal 2019. And then on page 12-61, we provide an explanation of any internal audit areas that were considered high risk that are not incorporated in this plan. And so it's a complete communication as required by the State Auditor's Office of the high-risk areas, the internal audit planning, and what we as internal audits considerations are in preparing this plan. So with that, I'll be available for any questions.
Members, are there any questions for Ms. Martin? In that case, thank you very much. Excellent presentation, Ms. Martin, and thank you very much for all your work and, I must say, for your flexibility in rearranging and discussing the risks and the proposed audits. Congratulations also to the Compliance Department for your excellent work during this time. Is there a motion to approve the sorry? Is that right?
Where to go here? Well, actually,
No. I have to do these. I have to do these.
No.
I have to approve it.
Nope. We'll do that once we come back from closed session.
Pardon us a minute. Ms. Doyle has to straighten me out.
We take these up after we come out of closed session.
Why? These are...
It includes the internal security.
We could do this and then just approve that one. But, okay. I have been straightened. In addition, at this time, the Oversight Committee will move to closed session to take up Agenda Item 15. Given the sensitive nature of the discussion about information security and potential vulnerabilities, the Texas Open Meetings Act authorizes state governing bodies to meet in closed session to discuss a security audit. We will go into closed session pursuant to Texas Open Meetings Act, Section 551.076, to discuss a security audit. In addition, to minimize the number of times the Oversight Committee is going into and coming out of closed session during this meeting, the Oversight Committee will also take up item number 22 while in closed session to receive advice from counsel pursuant to Open Meetings Act, Section 551.071. The following CPRIT staff will join the Oversight Committee in the closed session. The following CPRIT staff and others will join the Oversight Committee: Elisa Martin, Dan Graves, Heidi McConnell, Terry Simon, Kristen Doyle, Cameron Eckel, and Wayne Roberts. The time now is 11:57 a.m. And for those watching or attending, we won't have very much at all when we come back. We will approve the audit reports and then we will adjourn. So thank you all. We are in closed session. Oversight Committee now reconvenes in open session. The time is 12:23 p.m. There is no action item on item number 22, but turning to agenda item 15, are there any questions for Ms. Martin? And if not, is there a motion to approve the Communications Internal Audit Report and 3 follow-up reports? Second? All in favor? Aye. Motion carries. Is there a motion to approve the FY 2019 audit plan?
So moved. Second.
All in favor?
Aye.
Motion carries. Is there a motion to approve the FY 2018 Internal Audit Annual Report?
So moved. Second.
All in favor?
Aye.
Motion carries. Members, thank you very much. I believe that I need to announce the next regular Oversight Committee meeting will occur November 28th. The calendar for FY 2019 meeting dates and subcommittee meetings is in your packet behind tab 17. Please, again, look at that. Report any conflicts. If there is no further business and no objection, the chair moves to adjourn this meeting. Is there a second?
Second.
All in favor?
Aye.
Motion carries. Thank you very much. Meeting is adjourned at 12:24 p.m. Thank you.